In this section, we will be discussing the management of a scalp tumor patient seen in our practice, expounding on diagnosis, management, operative planning, and adjuvant therapy involved in this patient's care. Objectives for this section include being able to identify commonly encountered tumors of the scalp, to understand their etiology and pathology, to understand basic diagnostic measures to take, and to have a basic understanding of potential reconstructive needs. Here we have a case of a 75-year-old gentleman with a past medical history significant for large sun exposures, growing up on the beach and spending many years sailing without consistent efforts at UV protection. As so often is the case, his lesion was noted by his barber. He was advised to seek medical examination from his dermatologist and thus presented for evaluation shortly thereafter with the following lesion. So looking at our algorithm from the chapter, we have a large papular pigmented lesion with irregular borders and a sun-bearing area. This is obviously concerning for a melanoma, which we now know is an aggressive form of skin cancer with a high metastatic potential. And indeed, any lesion that matches this description should be presumed to be melanoma until proven otherwise. So, out of significant concern for malignancy, a punch biopsy was performed in the clinic. The pathology report would find a 2.5 millimeter Breslow depth melanoma of the superficial spreading variant. It was also noted to be positive for a BRAF mutation. Staging for this melanoma placed the patient initially at a stage 3B. Given the depth of the melanoma, resection was discussed with the patient, along with the need to perform a sentinel lymph node biopsy, given his increased potential for metastatic disease. Preoperatively, certain considerations had to be made in order to close this problematic wound. Though the lesion itself was only about a centimeter or two in size, an additional 2 centimeter margin would need to be included given the depth of the melanoma, which would leave a sizable defect at the scalp vertex. Primary closure of a wound this size on the scalp vertex would not likely be accomplished without recruitment of local flaps. Skin grafts can sometimes be used to close the wounds in patients that may not tolerate longer operative times or otherwise not concerned with cosmetic appearances. However, in this patient, we felt we could achieve closure with local tissue. We marked out a 2 centimeter margin around the melanoma itself and also included an area to the patient's left, which was a biopsy-proven seborrheic keratosis, which you can see on the left on the screen. We included this in our margin as well as so not as to confound future question of recurrences. We then injected a radioactive isotope, technetium-99, intradermally and subcutaneously, and then methylene blue to assist with sentinel node identification. Using a number 15 blade scalpel, we came down through the skin, subcutaneous tissue, and through the galea down into the periosteum, as this was a melanoma that had potential for deep invasion. We then placed a marking stitch at the 12 o'clock superior position of the specimen and sent it for evaluation of the deep margin with frozen sections, confirming that it had not invaded through the periosteum, which would have necessitated removal of the outer table of bone. After confirmation that the deep margin was not involved, the specimen was passed off for permanent section for closer inspection of the margins and further testing. Following resection of the lesion, the ensuing defect measured 25 square centimeters. Given the sizable defect and the challenge of rotating a single flap this large into it, we decided the best solution would be to elevate 3 separate rhomboid flaps, each measuring about 16 square centimeters, for a total of 74 square centimeters of local tissue rearrangement. We undermined widely at 360 degrees in the subgaleal layer around the resection site in order to provide further mobilization of the designed flaps to provide as much of a tension-free closure as possible, while limiting disruption of the blood supply to the scalp tissue. We were then able to rotate each of these flaps into the defect to close this in its entirety, securing the flaps to each other using a combination of acrodermal suturing and closing the superficial layer with proline sutures in an interrupted fashion. Notably, this patient would also undergo a sentinel lymph node biopsy of the neck nodal basins for evaluation of metastatic spread. Fortunately, these nodes were found to be negative on final pathology. So here is final closure on the table. And here's the patient at 2 weeks. You can see how his hair-bearing scalp was largely preserved and used to reconstruct the defect without necessitating a regional or distant flap. PD-1 checkpoint inhibitor therapy was discussed with the patient, but he declined to initiate this treatment given no notable evidence of spread, opting for close surveillance instead. Given his stage 3B diagnosis, we know that his 10-year melanoma-specific survival is about 77%. Statistically speaking, he's also at a 10% increased risk for developing a secondary primary melanoma elsewhere on his body. Given this, recommendations were made for the patient to follow for total body surveillance with his dermatologist every 3 to 6 months for the next 5 years, as well as basic labs, including LDH, or lactic dehydrogenase. It was also discussed with the patient that he would follow up with his melanoma surgeon every 6 months for 5 years, as well for evaluation of surgical site recurrence. Furthermore, he would undergo full body PET scans every 6 months for 5 years to evaluate for development of metastatic disease. And here the patient is again at 5 months post-operatively. He's healed, he has an excellent cosmetic result, and his hair growth appears largely normal, covering most of his operative sites and scarring.